So three, two, one. We are live. Please start the session.
Okay. Hello and good evening, everybody. Today, in continuation with our E-Gurukul series, Juventus is really delighted to present again Dr. P C Mahapatra for his kind guidance and teaching on various interesting topics. And today's topic is equally interesting. Uh, so for continuing this series of surgical skill transfer and solving clinical dilemmas, today Dr. P C Mahapatra will be giving his guidance on surgical procedures in endometriosis. And as you are aware, he is a mindful of all the teaching experiences. And this particular topic is very close to him, close to his heart. And we would request now Dr. P C Mahapatra to start his lecture. So be ready to get mesmerized. Thank you.
Thank you, Dr. Devan and the team of Juventus for the academic partnership and educational program and a series of E-Gurukul and I welcome all the viewers to the E-Gurukul program and episode 7. And in fact, it's a Juventus initiative and it was formulated and conceptualized by Mr. Alad, Mr. Diwan, and the whole team. It was for 6 episodes. And then we thought that whether we'll extend and on request of our viewers and all that, and my friends, philosophers and guides has stimulated me to continue this program. And that's the result of this episode 7. And each episode we have taken a separate subject in which the clinical and surgical dilemmas are being discussed at length. And I share my experiences, maybe wrong, maybe right, but it's a own experience which I share which I have for the last more than 3.5 decades of my career in obstetrics and gynecology for that. And you people have stimulated me to continue this program. And today is a program, very common disease and very complex disease, and where Lord can only help to solve the dilemmas for that. Well, today the topic is endometriosis. And endometriosis is not uncommon in day-to-day clinical practice in obstetrics and gynecology. And day in and day out, every one of you must be facing this clinical challenge of endometriosis in various sections of the populations in the health, starting from the adolescent to the reproductive age group and perimenopausal and medical, surgical. All the challenges are there since the last few decades. And when I think of endometriosis, I cannot start the subject before remembering one of the patient of mine. This is really a patient of mine whom I cannot forget. And whenever a subject of endometriosis comes, the face still is visible in front of me. This is the real life history which I have faced. The patient is a 38-year-old. He has presented to me history of progressive dysmenorrhea since menarche. Laparotomy was done at the age of 16 years because at that time laparoscopy was not available. Somebody has done a laparotomy at the age of 16 years for bilateral chocolate cyst of ovary. And after that, she was relieved of the symptoms for 6 months only. And after that, because of the pain, taking analgesics off and on, married at the age of 20, investigated for infertility. Then laparoscopic surgery was done twice, and persisting pain, ureteric stenting for 3 sittings was done because of the hydroureter, and laparoscopic surgery done twice. Ureteric stenting was done along with that. Persisting pain and infertility, and for the infertility, IUI was done 6 sittings, IVF was done 3 sittings, and tons of medical management starting from progestogens, danazol, GnRH analog, Depo-Provera for years. Presenting with severe pain to me, with adenomyosis and chocolate cyst ovary, right? And therefore, at the age of 38, I planned. She was very fed up with this pain and all that, and that's why we planned for laparoscopic hysterectomy. And when I put a scope, nothing was visualized. Everything was pasted. Therefore, I'm not a very aggressive surgeon. I decided I always have my own limitations for that, and I don't have an ego that I will complete the procedure at all costs. And that principle I maintain it for the safety of the patient, not at the cost of the patient. I will do my surgical expertise and experiment with that. And therefore, I converted to a laparotomy. And with the laparotomy also, it was very, very difficult hysterectomy with bilateral salpingo-oophorectomy. It was successful at the age of 36 years. Now, after that, she was relieved of symptoms for 6 months only. And then she developed her severe dysphagia with pain in right iliac fossa. And on examination, endometriotic nodule in the vault and posterior fornix with cystic lump in the right fornix. Sonography revealed residual endometriotic cyst with evidence of vault endometriosis, not relieved with medical management. And from Pathi to Pathi, Tirupati to Pashupati, and from Babas to Mamas, attempted suicides twice, rescued, and then decided for surgery with colorectal surgeon. I was very apprehensive, but seeing the condition of the patient, I agreed for this with the colorectal surgeon. Excision of the cyst was done, and rectosigmoid lesions and ureteric dissection with stenting was done, and colostomy was done because it's a completely engulfing the rectosigmoid. And patient was discharged uneventfully from the hospital with an advice by my surgical friend that I will do the closure of colostomy after 3 months. She was absolutely all right for 3 months. And unfortunately, during the closure of the colostomy, she died. Colostomy was absolutely normal by the surgical friend, and she died on 4th post-op day due to blood transfusion reaction, which is really pathetic. And therefore, I was really thinking that I'm an unlucky gynecologist. She's an unlucky patient. See, the patient was born with pain and died with pain. Where is science? Science fails. Endometriosis in women's health is like that. It's a tragedy to the women and challenge to the gynecologist for that also. So this particular patient has really influenced me to do more and more work and think about this particularly challenging situation or complex disease called endometriosis. And therefore today, let me share with some of my experiences of clinical and surgical dilemmas and discuss with you over a period of the 2 hours. Now, evidence are there. There are a lot of evidence when endometriosis comes, any disease comes, there is a lot of evidence for that. Evidence is there, but experience is also there, but excellence is a still question mark for that. We have still not attained the excellence as regards the endometriosis is concerned for that. The basic facts for endometriosis, I will just narrate that it's an enigmatic disease. It's a disease of coping with everybody. Still remains as disease of theories. We do not know the cause, and pathogenesis is still under dilemma. It is frustrating to patients and challenging to gynecologists. And we have, with the conceptual advances of the newer technology, improved diagnostic tools like sonography imaging and other sonographic and other imaging modalities, and a multimodal approach in treatment, both medical, surgical, and a combined treatment, and from radical to more conservative and tissue preservation, and from research to practice. We have got a lot of innovations in the newer molecules of medical management, skills regarding silk and technology regarding the surgical management. We have improved, but there are a lot of pitfalls, and still there is a long way to go. So endometriosis is a disease. When you think of scientific thoughts, ask yourself, is endometriosis a local or a whole body disease? When we think that it's not limited to the pelvis only, female pelvis, apart from that, it's a distant disease, and therefore it's a whole body disease. And therefore, we do not know, we do not say that it's only restricted to the below the pelvic brim. Is it an inflammatory disease? Because inflammatory components are being discussed with the scientific experts and particularly the researchers for that. Is it an autoimmune disease? A lot of researchers have described this. And is it an endocrine disease? Although the relationship with the hormones and the treatment modality with the relation with the estrogen, progesterone, and GnRH analog, is it an endocrine disease? And these are all scientific thoughts which is pondering in our mind for that. And therefore, this is a pathogen. When we call it pathogenesis, hypothesis is abound, but facts is minimal till date. And after years of research also, we are not able to pinpoint the exact pathogenesis. But the only thing is very certain, that there are two processes which is involved in endometriosis. One is initiation of the pathology. Second is progression of the disease. So initiation of an endometrial implant, the ectopic endometrium is implanted in the peritoneum, and the cause of initiation, endometrial implant, is not yet known. Although we have a happy marriage between the metaplasia and implantation theory of Sampson and Ivanov and Mayer, and controlled by genetic, immunologic, endocrine, and mechanical factors. We are not very certain why there is an endometrial implant for that. But after that, the progression is an important part for that. Progression and invasion is also a continuous process for that. So it is a progressive disease, it is an invasive disease, and really it matters much for this. And progression and invasion and aggressive disease, this is mainly because of some of the hormones and the milieu of the body which controls the progression, which is little understood, but the initiation is not being understood for that. Progression is little understood, the relationship between the hormones which is influencing the body, the ovary place of estrogen, which also stimulates that. And apart from the theory of lymphatic and blood spread, suggested etiological factors in the pathogenesis of endometriotic implants for that. Still, there are some unanswered questions. All women do not have endometriosis, though almost all of them do have retrograde menstruation. Severe disease develops in some women, but not in others. Disparity between extent of the disease and severity of the symptoms. We do not know there is a defective correlation between the grades of the disease and the severity of the symptoms, meaning thereby that the grade 4 will be a more severe symptoms than grade 1. It's not like that. Even we find asymptomatic but grade 4 disease could be there, and very, very symptomatic in grade 1 disease for that also. So how can you explain? These are some of the unanswered questions which comes to the mind now. And when we see the case and the spectrum of the disease for that. And genetic and immune function could possibly explain the fallacies. And till date, we are really unknown. We are not found the pathogenesis for the case. So the genesis of endometriosis, again coming back to that, we know that there is an endometrial implant. And earlier we were saying that yes, it is a presence of endometrium other than the normal uterine lining. It's an ectopic endometrium for that. And that is manifesting that. But of late, researchers have proved that the utopic and ectopic endometrium are completely different. The utopic endometrium and ectopic endometrium are completely different. Utopic endometrium, they are also controlled by hormones, whereas secretory changes comes. But in ectopic endometrium, in endometriosis, we always find the proliferative endometrium for that. Are they similar? Are they de novo arising from the same thing? So that is a very important question comes to mind. And now it has been proved that they are not similar. Survival of detached endometrial cells. When we believe in implantation and the endometrial cells is implanted on the peritoneum, the survival is a very important factor. Whether it's a degenerated cells which has not able to survive, this is one aspect. And when on the peritoneal surface where the implant is let down, I think they should have a quality to receive that and propagate that in implants for that. And what is that? Mechanism where in some women it develops and in some women it doesn't develop for that. And endometrial cell proliferation continues, neovascularization occurs, increased aromatase E2 activity in utopic endometrium is seen. So basically there is a difference between utopic and ectopic endometrium for that. Now coming to the spectrum of presentation. The spectrum of presentation starts from the surface endometriosis and a mild variety of different, either a black or a white lesions or a different endometriotic lesions or the surface of the ovary, on the posterior surface of the uterus or the peritoneum is the commonest site for that. To deep infiltrative endometriosis, more than 5 millimeter depth it invades, and particularly the rectosigmoid or deep infiltrative endometriosis. Pelvic adhesions could be there. Jellies, very often we find it, and pelvic adhesions and jellies are all the forms of that. And adenomyosis is also an important, the diffuse or generalized. If it's grossly and uniformly enlarged uterus, it is diffuse or generalized, or whether there are many cases where a localized adenomyoma is there, there is an adenomyoma rather than adenomyosis. And ovarian endometrioma are of various nature. It could be a bilateral, it could be a unilateral, and the size and configuration are also variable for that. And there could be a rectosigmoid endometriosis, or most pitiably, there could be a combination of all these. The uterus is affected by adenomyosis, along with that, the both ovaries, the peritoneum, the jellies are there, the adhesions are there, deep infiltrative endometriosis are there. So in some cases, there is a severe degree of endometriosis for that. So basically, there are 5 different phenotypes of endometriosis, and the early and late are grouped according to the American Fertility Society, where we find the surface endometriosis or ovarian endometriosis surfaces. These are all early endometriosis, whereas the advanced endometriosis are deep infiltrative endometriosis, or ovarian endometrioma, or adenomyoma, or a combination of all these could be really associated and could be really challenging situation for the surgeons. Apart from this, the atypical presentation or spectrum of presentation is not only confined to the genital organs. For that, the bladder and ureteric disease, it could be there involving the ureteric disease, because hydroureter is a common phenomenon when there is an extension, or bladder extension when we find, in many cases when we find that in cystoscopy there is a lesion and bladder is completely involved with the endometriosis in the uterovesical fold of peritoneum. But unfortunately, the posterior disease is more common than the anterior. Rarely we find the anterior segment, the endometriosis, but most often it is limited to the posterior compartment for that. But bowel endometriosis could be seen very often for that. And in bowel, rectosigmoid is the commonest form, but the rectosigmoid, there could be two types of lesions could be there. One is a constrictive lesions and another non-constrictive lesions. Constrictive lesions are more dangerous and is amenable for resection, whereas the other lesions could be saving the endometrial lesion from the surface of the rectosigmoid can suffice it. Another is a scar endometriosis. When we believe that endometriosis is implantation theory, the scar endometriosis is an issue for that. An abdominal scar following hysterectomy, following the cesarean section, following tubectomy and all that. The exact nature why it happens is not being known. But hysterectomy, there was a lot of incidents, more common in hysterectomy, where earlier it was being done for termination of pregnancy, so that we think that the the decidua and the early pregnancy is more responsible for this, but still we do not know the. But certainly implantation could be a very logical way to explain, because in in the port site, when laparoscopic surgery is very common in endometriosis, we have experienced in the port site endometriosis during the delivery and the retrieval of the tissues, when it is done blindly and without any cover, or without any lap sac, or without any port. I think they're more common to port site, which I have also experienced that. Peritoneal endometriosis, umbilical endometriosis, and of course the distant sites, the lungs, the nose, the other sites, and these are all spurious hemoptysis and all that. Cyclic could be, there are a lot of reports for that. And worst is the recurrent endometriosis, because every time you treat the patient and again the recurrence will be there. So in other words, the broad spectrum of presentation, variable prognostic scoring, and individualized treatment for that. Now coming to the symptomatology, there is an array of symptoms for that, but the predominant symptom is the pain, pelvic pain, dysmenorrhea, dyspareunia, infertility. Pelvic lump, if the size is more, pressure symptoms, bowel and bladder symptoms, and quite often we find incidental detection of endometriosis. By virtue of some problem, you do a scan and you find it. And even in grades advanced stage also, asymptomatic cases could be detected during the time of tubectomy, where you detect it, or during the time of investigations for some other cases, you find by sonography there is a structural lesion for that. These are asymptomatic. Now, the diagnosis. When the diagnosis comes, again, history is very important. The analysis of the symptomatology, as I've already told, could lead to think about this disease. And on examination, the pore-abdomen examination, the perspeculum examination. Perspeculum examination, we find that the cervix is drawn up in quite good number of cases when there is an extensive disease. And one of the things I find, the association between nulliparous erosion. In a nulliparous erosion, when we find about 80% of the cases, they are associated with endometriosis for that in some form or other. This is my observation, which I have noticed it for that. And of course, PB examination and PR examination, you can find the tender nodule, or you can find the irregularity, the restricted mobility of the uterus, or a pharyngeal mass for that. Now, imaging has really given an opportunity for non-invasive diagnostic modality, and sonography, in the high resolution sonography with the machine and man. Now, I think majority of these can be diagnosed. Even smallest lesion could be diagnosed, but it should be structural. If there is a structural lesion, there should be suppose an ovarian cyst, a cystic lesion, or a structural abnormality is there, that could be noted. But a surface endometriosis detection by sonography is very, very difficult for that. One could suspect that there could be endometriosis if there is no structural lesion, if there are adhesions and all that, the displacement of the ovary backwards and posteriorly in the POD, and which is not being moved, and that is a fixed thing, and there could be some suspicion from sonography, but the definite diagnosis is not that unless it's a structural lesion for that. Color Doppler can really help you for distinguishing and differential diagnosis between a cystic ovary, which is benign, or a malignant. CT MRI, when it is needed, CT and MRI can be of help, particularly in those cases where there is a need for that, and more so in adenomyosis. In adenomyosis, MRI is a diagnostic. In 60 to 70% of the cases of the diagnosis of adenomyoma, this could be confused with the myoma. But the differential diagnosis from myoma with the adenomyoma is not by sonography, and more approximate and correlable finding is always with MRI, because in MRI, when we find the junctional zones, adenomyosis can be better defined than the myoma for that. Now, the endoscopy. I think endoscopy, laparoscopy has changed the situation, and it's a gold standard for endometriosis, not only for diagnostic, but for the therapeutic also. And laparoscopy is still now considered as the mainstay of diagnosis and therapy in a mild, moderate, or a severe disease of endometriosis, and for a fertility promoting to a radical surgery. This has played a very major role, laparoscopy. Now, hysteroscopy. Hysteroscopy is there are pointers when we are doing a hysteroscopy for the hysterolaparoscopy for the infertility. On hysteroscopy, can you suspect that there could be an endometriotic lesion? Yes, you could suspect. There are two things you find out: that the position of the ostium, the two ostia, when it is fixed on the lateral aspect in the slightly upwards position, it is absolutely normal. But in endometriosis in severe degree, you find the ostia displaced posteriorly and deeply, and therefore you can suspect. That is one. Second is that there is a longitudinal serrations at the level of the fundus. There are longitudinal serrations at the level of the fundus. It signifies more often adenomyosis for that. But these are all pointers for that. And apart from it, the non-invasive biomarkers, there are a lot of research which is going on. Blood and saliva, there are tests. Genomic and metabolomic markers are there, which is not being foolproof. And these are all on experimental stage for that. Histopathology. When we come to the histopathology, confirmation of endometriosis by histopathology is there, but there are pitfalls and there are variations of all that. Even we find the surgeons are confirmed that it is a chocolate cyst, sending the specimen and cyst wall, and on receipt they don't find the diagnosis, histopathological diagnosis endometriosis. They said that hemorrhagic cyst. So hemorrhagic cyst and endometric cyst could be different, and therefore there could be pitfalls and variations in the histopathology for that. Adolescent and endometriosis, it's not uncommon. Prevalence is 12% in Indian data. Complacent attitude and delayed diagnosis is the major factor. Pitfalls in sonography, because we cannot do the transvaginal sonography for that, and there is a pitfall. Laparoscopy, we do not immediately do it, a restricted use. Future fertility issues could be there if you neglect it, and recurrence could be there, and other rare causes. When we find a persisting pain and all that, and on sonography, of course, they could detect it, non-communicating functioning uterine horns for that. And non-communicating, I have already in the last episode, I've described, I have shown some of these slides, some of the videos pertaining to this endometriosis, and non-communicating horn can give rise to severe pain, excruciating pain right from the time of menarche for that. Coming to the ovarian endometriosis, the types of ovarian endometriosis, I will divide into three main different types according to the surgical philosophy or a dilemma: extra-ovarian versus intra-ovarian. Majority of the ovarian endometrioma are extra-ovarian, because once the endometric lesion is implanted, it folds into it, it is gone, and ultimately that part is being inverted into it, and there is a pseudo capsule and which forms the cyst. And therefore, in the majority of the cases, when you are dissecting by surgery, in majority of the cases, the cyst wall ruptures, and that is because of the extra-ovarian. Intra-ovarian means it's completely like an ovarian tumor without any adhesions, nothing like this, and it simulates the hemorrhagic cyst for that. And intra-ovarian is about 10 to 20% of the cases we find completely enucleated cyst could be there, and without any extra, I think, invagination of the ovarian surface. There is no invagination of the ovarian surface in intra-ovarian, whereas there is invagination and in the extra-ovarian, so that it ruptures that. Type 1 versus type 2 is also the same thing, is type 1 and type 2, where majority are type 1 are extra-ovarian, type 2 is intra-ovarian in this. And one of the important thing, dissectability versus non-dissectability. And we know that the type 1 can be easily dissected and easily dissectable, and the cyst wall can be peeled off very easily for that. But in some cases, the cyst wall are not easily dissectable, and these are non-dissectable things for that. So the patient's profile varies, the surgical profile varies. When as a surgeon we face it day in and day out, different types of lesions for that. And the differential diagnosis of ovarian endometrioma starts from dermoid cyst, hemorrhagic cyst, tube ovarian abscess, and malignancy for that. So think of all these dermoid cyst, because it's a the same echogenic material could be seen for that. But if you find an acoustic shadow, I think it's more in favor of dermoid cyst. Hemorrhagic cyst is again, I think, differentiable from the endometric cyst, because the clots, these will have the same echogenic casting for that. Tube ovarian abscess, when there is a pus also, the contents are a little echogenic for that. And of course, more important is to differentiate malignancy for that. There are few cases where endometriotic cyst could turn into malignancy, and these are really a case to be diagnosed much earlier for that. And therefore, in these cases, endometriotic cyst malignancy, the IOTA criteria could be there, the M lesions or B lesions could be differentiated, and most important is a color Doppler can differentiate malignancy from the benign thing for that. When we come to the management, the basic principles of management are three. Alleviation of symptomatology, relief of the symptoms is number one. Second, arrest of the progress of the disease, because it's a progressive disease, we want to arrest the progress of the disease. And third is, majority of the cases do present with infertility, promotion of fertility potential is there either by surgery or by medicines or by the different forms of ART management. Promotion of fertility potential has to be looked into it. Now, the general protocol of management deals with the thorough clinical evaluation, age, fertility status, symptomatology, severity of the disease. This should be a first foremost thought of the clinicians for that. And before any treatment, and particularly for surgical treatment, pre-treatment counseling is absolutely essential. Sonography and clinical correlation must be there, and modalities of therapy should be really planned for that. So the therapeutic modalities mainly in endometriosis could be 4: expectant, medical management, surgical management, and of course combined management. And today I will not go into the other forms of management, expectant, medical, or a combined management. I will stick to my topic of a surgical management and how you deal with that. I will restrict this talk for today's episode for that. And therefore, when we come to the surgical management, I've already told, I've reiterated again that laparoscopic approach is the gold standard, a diagnostic as well as therapeutic. And in laparoscopy, it could be meticulous diagnostic search, staging of the disease could be done, concurrent therapy could be done. You decide whether you go for a radical versus conservative surgery for that. There is a place for debate in preoperative GnRH analog before surgery, whether it's a beneficial or not, whether you go for a staged procedure, because staged procedure, the great surgeon Donage has devised a 3-stage procedure for that. So initially what you do, initially you put a scope to diagnose, and when there is a cyst, you just drain the cyst. You don't do the surgery. You don't drain the cyst, give GnRH analog, and after 3 months, do the surgery and do the cystectomy and the detailed surgery of adhesiolysis and all that. And 6 weeks later, again you do and confirm it, the adhesions and all that which is there. This can be really wanted for that. So this 3-stage procedure is not acceptable because our patients are not guinea pigs and they are not to be tried for that. But Donage has proved that yes, the fertility and the result is quite good if we subject the patient for 3-stage procedure. That is still controversial. Many people are not advocating this for that. Post-op management is important when really the recurrence is an issue for that. When there is a fertility is there, this is an important issue because the post-operative management are really a worrisome affair depending on these two, that promotion of the fertility and prevention of recurrence of the disease for that. And the laparoscopic procedures, what are the different laparoscopic procedures that can be adapted? I will show in my videos the different patterns of that. Drainage of the cyst is one, you drain the cyst, and fulguration, adhesiolysis. This is important because the restoration of the normal tubo-ovarian relationship is important. Normal restoration of the anatomy of the pelvis is important. So as far as possible, you try to make it. And cystectomy, if there is a cyst, you have to do a cystectomy for that. And cystectomy also, whether fulguration or cystectomy, there is a debate whether the size of the cyst determines that. When a cyst of less than 3 centimeter, fulguration can be a better option for that. And when more than 3 centimeter, you have to do for a cystectomy. The advantage and disadvantage are both there. If you're doing a cystectomy, the chances of recurrence are least. Whereas if you're doing a fulguration, the chance of recurrence could be more for that also. That is a point which one should understand for that. And doing a fulguration, the chances of the ovarian restoration of the ovarian function is more than when we're doing a cystectomy. When you remove the healthy ovarian tissues along with the cyst, when you're not doing a proper surgical philosophy, I think this could be reduce the fertility, affect the fertility potential for that in subsequent. In extensive disease, when the pain is a predominant symptom, presacral neurectomy could be added for that. But rarely, we gynecologists, we do not advise for there is no scope for presacral neurectomy. But in some cases, when the pain is a major process, I think this could be adopted for that. And of course, radical surgery is important. And this is depending on the fertility. This is depending on the age of the patient. And when the fertility is ignored or the patient is a child and the elderly individual is crossed around 40 years, she doesn't want that the normal restoration of the menstrual function because it's a really bothersome affair. So radical surgery remove the uterus and ovaries combiningly for that. But remember, this is one indication where you cannot keep the ovaries when endometriosis is there. Even if there is a mild disease in the ovarian endometrial surface, there is a chance that there could be a residual ovarian syndrome. That counseling must be adopted for that. And there is a risk of development of the residual ovarian syndrome. So radical surgery, there is one. And if you remove the ovary, I think the hormone, internal endogenous hormone or estrogen production is less, so that the proliferation of the postoperative and chance of recurrence is diminished to a considerable extent for that. Regarding the use of bipolar, regarding power source, the electrosurgical device, bipolar versus laser versus harmonic versus argon beam coagulator. Everything has been really searched and a lot of researches have been done for that. But a precise use of the power and least use of the power is most important, so that the healthy ovary has to be preserved for that. And of course, as a surgeon and doing particularly the fertility promoting surgery, Hemostasis is absolutely mandatory for that also. So a good hemostasis is necessary for that. So therefore, surgical management, the laparoscopic surgery is again the gold standard. Second important point, which is also important, the primary surgery is the best surgery. Remember that. If we are going for a recurrent surgery, it's a really troublesome thing, and at times it becomes inoperable. So primary surgery must be the best surgery available, particularly for that. And that depends on the surgical quality of the surgeons, the skill of the surgeons for that. And rating and skill of the lap surgeons really is judged by laparoscopic surgery conservative. I always say that in laparoscopy, let me observe an endoscopic surgeon doing a laparoscopic conservative surgery for grade 4 endometriosis and a fertility promoting surgery. And let me observe an hysteroscopist doing a hysteroscopic synechectomy. This is the pinnacle. Synechia in hysteroscopy and conservative surgery in grade 4 endometriosis and fertility promoting surgery. This will, from this, I will rate the quality of the endoscopic surgeons, not by doing a TLH, not by doing a radical surgery or malignancy for that also. So the rating and skill of lap surgeons depends mainly on the conservative. That's very so difficult is that. And therefore, in the surgical management, we have got pre-op, intra-op, and post-operative really SOPs, particularly for endometriosis. The preoperative place of GnRH analog. There are a lot of debates which is there in place of GnRH analog. There are some people who do not advocate GnRH analog preoperatively; they give it postoperatively. But I believe in different concept. I believe that pre-op GnRH analog, at least depending on the stage of the disease, not more than 2 GnRH analog at 1 month interval, preoperative facilitates the type of surgery. The surgery, the hemostasis is very good. The cleavage is very good. The surgical, I think, complications are less, more so particularly when it's in a vulnerable area, the dissectability is very good. And therefore, GnRH analog I always give in a preoperative. And postoperative, I don't want to give if the fertility is warranted for that. Early resumption of menstruation and function is essential. And therefore, we encourage that particular thing. Otherwise, if the fertility is not an issue and we are doing a conservative surgery and grade 4 endometriosis in laparoscopy, yes, you can give it post-operative, again a GnRH analog for a few months, you want it for that. But never you go beyond 3 doses because the add-back and other symptoms, other complications could be there. The benefits and risks should be outweighed for that and balanced for that. Now, intraoperative, I must say a few things. Over the years, we have learned there are few improvements on that. So regarding the vision, so I'm seeing the evolution of laparoscopy since my initiation of laparoscopy. At that time, the analog camera was there. A very analog camera of the best storage camera which was there, analog. Then the digital camera came. The single chip camera we have used at that time. Then subsequently 3-chip camera has come. Then the image quality, image 2D, SPICE, HD, high definition camera has come. Then the 3D camera has come. And of course, the 4K is there, another camera which has come in for that. So these are out of all these cameras, I think vision is important, particularly in difficult surgery. And more so when there is a good vision, you can have a good piece of surgery, you can reduce the complications to a considerable amount. Because if a vision is good, you can do the surgery very well. You can differentiate from the rectosigmoid to the lesion exactly for that. And therefore, endometriosis is a disease where in advanced endometriosis, I always say that 3D endovision. I've experienced all these and I'm now confirmed that 3D is absolutely mandatory for endometriosis surgical management, and this is important. Wherever it is not available, there's a different issue. But wherever there is a necessity, wherever there is availability, make use of it. And particularly in endometriosis and advanced endometriosis, 3D, I say that it's absolutely mandatory for that. That with such a judgment and with such emphasis, I'm telling this after my experience over all the varieties of the camera since inception for the last 3.5 decades. Then effective hemostasis is important for that. Bleeding, with the bleeding, I think it will really, quality of surgery is very bad, and most important is that postoperative adhesions will be there for that. So injection vasopressin. Normally we give a vasopressin in a case of myoma uterus or adenomyoma, but here also in a grade 4 endometriosis, you inject the vasopressin on the posterior surface of the uterus. You cannot inject on the cyst. Many people inject on the cyst wall also. That's all right. You can inject it. You can inject it on the infundibulum pelvic ligament also. But most important, in a grade 4 endometriosis, when we inject into the posterior surface of the uterus, I think there is a lot of benefit of the hemostasis for that. Third important is the preservation of healthy ovarian tissue. Always when we are doing a cystectomy, the healthy ovarian tissue must be preserved. So go through the right cleavage and do a good cystectomy for that. And cystectomy with a good cleavage can reduce the bleeding, and at the same time, healthy ovarian tissue can be preserved for subsequent fertility. Reduced energy sources as far as possible. When there is a bleeding, you just with the precision control the bleeding with the pinpoint power source for that. But otherwise, don't overuse the energy sources, and don't burn the tissues, because these also has an influence on the reduced ovarian reserve, and AMH after that will be grossly reduced for that. Sutures are debatable for that. It looks nice when you suture it after doing a cystectomy for that, but the many studies have shown that suture or no suture, I think adhesions are all same. Rather, in sutures, the adhesions could be more for that also. So there is a debatable issues for that. Optimum adhesiolysis is important. As I have already told, proper restoration of the anatomy is very, very important. Restoration of the tube ovarian relationship is very important. And one observation I have found, unilateral adnexectomy, when the fertility promoting surgery, when the many times we find that it is a case of unilateral disease, the other side ovarian tube is absolutely normal, but one side is absolutely mass, hydrosalpinx, and whole thing is engulfed into a different mass, and with the jelly and adhesions and all that. So that unilateral adnexectomy, if you remove it instead of doing a adhesiolysis and a cystectomy both sides, in those particular case, more so in a second infertility when there's a baby, and unilateral adnexectomy helps in two ways. It promotes the fertility, number one, with the healthy ovarian tissue. Second important, most important, that it eradicates the diseased part, so that the pain or the symptoms are completely relieved for that. So I have observed this, that symptom patients are very happy, and I have seen that many of the cases my fertility is being augmented rather than restored. It is augmented. Now, adenomyomectomy, there is a controversy and a consensus. When adenomyoma is a difficult adenomyomectomy, do a myomectomy is an easier procedure. Adenomyomectomy is a difficult procedure, and suturing is much more difficult in adenomyomectomy. But definitely, there are some advantages of localized adenomyoma where you remove it, so the pain perception, pain is relieved to a considerable extent, and fertility could be also augmented because of that. Avoiding injury to rectosigmoid, ureter, and other vital tissues. This is important, for which I say that the vision is all the essential step for that. Vision and less use of cautery can really avoid rectosigmoid, ureter, and other vital tissues for that. Adhesion prevention materials, the efficacy, I've tried everything for that, and the adhesion prevention materials efficacy is still a question mark. Nothing is absolutely tested to be really a unique thing for that, but a good piece of surgery with least hemorrhage and good maintenance of the hemostasis, with the restoration of the anatomy, and going to the right cleavage, and use of cautery, minimal cautery, can be a better way of preventing adhesions for that. Postoperative. Postoperative GnRH analog, I have already told that GnRH analog, when pregnancy, fertility is not an issue, you can use the GnRH analog. And for recurrence, progestogens could be a very good agent for that. Progestogens, particularly the dihydrogesterone or micronized progesterone, use an early pregnancy. You promote the pregnancy, you advise the pregnancy to be as early as possible, because the window period is very, very important. Within 6 months of surgery, and the majority will conceive for that. And therefore, don't waste this wealthy period of 6 months to maximum 1 year. So during that time, you make attempts of spontaneous conception or assisted conception, either by IUI or some other alternative methods for that. And prevention of recurrence is a major issue, where the recurrence can be done, as I've already told, that GnRH analog can reduce the chance of recurrence for that. Now, is there a place for conventional surgery? We are all dealing with the laparoscopy in the current situation of scopy and scanning. In the era of scopy, when we speak of conventional surgery, it affects our dignity. No, don't think that it's our dignity is affected. And there is no dogma in science. In cases at the cost of the patient, you cannot do a drastic experimental laparoscopic surgery and taking your credit of a surgical skill for that. Don't do that. But place of conventional surgery, age is an important, extent and volume of the disease is important. What is the extent of the disease? What is the volume of the disease? Where is the nature of the disease? That the site of the disease? Recurrent disease again. Scar endometriosis, they usually do not respond to medical management. Failed medical and surgical treatment is already failed for that in repeated surgery, therefore. And therefore, the conventional surgery is really helpful for that. But here also, the techniques and skills are important. Preventive surgery is important. How to avoid injury to the rectus sigmoid. Going through the proper cleavage more towards the uterus is important for that. And how to avoid the ureteric injury. That's a preventive injury is very, very preventive steps are very much more important in conventional surgery for that. In endometriosis and infertility factors are anatomical distortion, damage of reproductive organs, poor quality of oocytes and defective embryogenesis, reduced ovarian dissolve, poor endometrial receptivity and implantation issues, and early pregnancy failure. Now, for the legal reasons, now many have recommended that before going for contemplating for surgery in endometriosis, for infertility promoting surgery, you do an AMH first, and then after that you do again AMH, because normally we find in endometriosis also ovarian resorb is less, AMH is less from the beginning. So they may not blame that yes, you have reduced our ovarian resorb after the surgery for that. That could be a medical legal issues for that. Endometriosis infertility, I've already told early stage 1, stage 2A, advanced stage 3, stage 2B, 3 and 4. So results of infertility treatment, surgery is the mainstay. Fertility promoting laparoscopic surgery is an art and skill. I think remember that this is an art and skill. And primary surgery is the best surgery. Again, I want to reiterate that window period is of importance. After surgery, 6 months window period, you must try all your efforts to achieve pregnancy. ART augments, surrogacy and adoption are the other alternatives for that. These are special situations where this scar endometriosis is one of these situations. Rectosigmoid endometriosis, another situation where it is a constrictive, it is a constricting the rectosigmoid. I think there the colostomy and extensive surgery is needed for that. But in the case of where it is not a restrictive thing, shaving of the endometriosis, shaving of the endometric lesion from the rectosigmoid, and that could be really a better procedure for that. Residual endometriosis, adenomyosis and adenomama is difficult, and mixed pathology is there. So therefore, when ovarian endometriosis is there, when the pregnancy is, if the uterus is normal, it's not an adenomyoma, even bigger size endometriotic cyst, is the prognosis is much better as far as the fertility promotion is concerned, rather than the mixed pathology. When there is a small endometriotic cyst, but the uterus adenomyosis is there, and fertility is really a major issue, because adenomyosis, the result of surgery is not very important unless there is an adenomyoma. If it is a diffuse endometriosis or a generalized endometriosis, it's not amenable for surgical procedure unless you go for a radical procedure and remove the uterus. If it is not responding for fertility promotion, it's not a rewarding surgery for that. And mixed pathology are really dangerous for that. So the future is a conceptual research is going on, and the trend towards innovative medical management. We want an innovative surgical procedure is so complex, and the skill of the surgeon is necessary. The highest skill of the surgeon's endoscopic surgery is necessary for that many researchers are targeting for the innovative medical management and simple surgical procedure. It's not a complex surgical maneuvers. Whereas there, I always say that as a laparoscopic surgeon, I want an endometriosis powder or endometriosis molecule, which I will do a sprinkle a grade for endometriosis by laparoscopy. I will sprinkle the endometriosis powder through the secondary port and do nothing. And after 3 months, the endometriotic powder will all kill the endometriotic tissues and resolve. And after 3 months, when you do a check laparoscopy, when you find absolutely normal uterus, ovary, and tube and all that, so no cutting, no dissection, no adhesive lysis, no cystectomy is necessary for that. I'm I'm really wishing that the dream capsule will come, the dream powder will come, so that the touch and vanish phenomena will be there, so that the endometriosis surgery will not be necessary in majority of the cases for that. So to conclude, it is extensively studied but least understood. Increased prevalence is there, association with infertility, frustrating symptomatology. It is a sex steroid dependence, rational therapeutic approach always, and lastly, living with endometriosis or living endometriosis. If you could live endometriosis, LEAV versus LIVING, in endometriosis, it's not a malignant disease, but it is a disease which has to be coped up. We have to cope with the disease and live with the disease process for that. So living with endometriosis versus living endometriosis, till the future research is awaited for that. So with this introduction of the endometriotic and challenging situations for that, let me say about that video presentations of these clinical situations for that. Now, these are clinical situations which commonly being encountered by all gynecologists. See, the first and foremost is adolescent girl. Majority of the adolescent girl do have dysmenorrhea. And you see, day in and day out, adolescent girl, the mother comes with presentations of 16 years, regular cycle, with progressive dysmenorrhea, often on taking analgesics. We think that these are all primary dysmenorrhea, and this is gradually over the period, it will go on, it will be went up, and you just approach as a clinician, give some analgesics, clinical examination. To what extent? We cannot do a much more clinical examination in this adolescent girl for that, unless at best you do a PR examination for that. Do nothing, or counseling has to be done for that. But at least investigations wise, do a sonography for that. Rule out secondary dysmenorrhea, causes of secondary dysmenorrhea, or a structural lesion for that. If the structural lesion, think about endometriosis when there is a progressive dysmenorrhea, and if the sonography is there, sonography reveals no abnormality, nothing to be worried about it. You can continue with the same procedure of treatment, symptomatic treatment for that, to relieve the pain, and counseling that. And of course, is there a place of endoscopy? Because you have an endoscope, you have a laparoscope, you put in all cases to confirm the diagnosis. I don't recommend in that particular case a place of endoscopy. Say a big no to that, unless we find a sonographic pointers, unless it is not relieved with the medical management, then the surgery will be a last resort for that. If there is a sonographic pointers, of course, there is an endometric cyst and there is a symptoms which is not being relieved for that, yes, there is a place for laparoscopy procedure. Till that time, analgesics, antispasmodics, role of hormones, you can give it the role of hormones. Nowadays, the Dynogest ethenyl combination could be there, and this is appropriate where the cycle is irregular and the patient is having pain. This is the best form of treatment, combination of Dynogest with the ethenyl. There are many companies who are now going on for that role of. So this type of COC, specialized COC with a Dynogest molecule as a progestogen component, can help it to a greater extent. Place of any surgical treatment when it is not relieved, in the last procedure, you can do that. So the message is dysmenorrhea is a common presentation in adolescents, needs special investigation and treatment. If associated with menorrhagia, sonographic pointers could be there, usually relieved with analgesics and antispasmodics. Counseling of the adolescent and parents are important. So parental counseling is more important. The counseling to the mother is more important. She is not worried about the daughter's pain. She is worried about whether my daughter will be a mother or not after 10 years after marriage or that. That is the thinking of the mother for that. So follow-up is absolutely essential for that. Now, this is another problem. Again, adolescent girl, 18 years, progressive dysmenorrhea, but sonographic evidence of endometric cyst. You do a sonography, there is a endometric cyst of 4 centimeter diameter. Uterus was normal in contour and dimension. The adenomyosis is not there. Only endometric cyst of 4 centimeter. Does it require surgery? What's your plan? Does it require surgery, medical management, or a surgical management? I think we cannot go for a surgical management from the beginning. Medical management, you strive for that, and if it is not responding or the size increases, then go for a surgical management. So here in this particular case, the medical management could be a priority rather than the surgical management. So that's why before going contemplating for any surgery, I always say decision is important, equally important than dissection for that. And that makes you really a surgeon par excellence. So decision and dissection is more important for a surgeon for that. And therefore, I always remind you that it takes 1 year, it takes 5 years to teach you and to train you how to do surgery. But it takes 25 years to teach and train you how not to do surgery for that. Say not to do a surgery. So these are the examples where you don't do a surgery for that. This is another example. 20-year unmarried, progressive dysmenorrhea, menorrhagic cycle for 2 years. There is a history of lap surgery 3 years ago for endometriosis, not relieved with medical management. Sonographic findings, evidence of bilateral ovarian cysts, and the patient is not relieved of the dysmenorrhea. What's your approach? Again, there is a history of surgery. You do a sonography to find out the size of the myoma, to confirm there is an endometriosis. Most probably that could be there. And most importantly, about the uterus, whether the adenomyosis or a normal size uterus. That also is a very important pointers for the subsequent prognosis for that. And other possibilities. There could be other possibilities of the rule out malignancy for that also, because these are all, no, don't think that the adolescent girl is immune to malignancy and all that. Any other investigations, you do a color Doppler for that, you do a CT MRI for that. And treatment modality, what is the treatment modality for that? Medical, surgical, or if the surgical, whether laparotomy or laparoscopy. In view of all this, medical management you can try, but medical management, if the size is more and it is responding to a limited period of time, a temporary period, that could be benefit, and then you can go for a surgical. And if it is a surgical, I think even if there is a lap surgery or laparotomy, I think in the current situation, I will not advise for a laparotomy from the initial phase. Laparoscopy is the rule. And on laparoscopy, we find place of pre-op GnRH analog. I must give this pre-op GnRH analog 2 doses before going for a surgery, because it's a previous surgery has been done. The type dose, the same leuprolide 3.75 at 1 month interval, 2 doses, not more than that. I will give it. There are a lot of controversies. I have told about the debates and all that, but it's my personal experience. Routinely for infertility, I give all cases the endometriosis, give a preoperative GnRH analog, then do the surgery with 3D laparoscopy with all hemostasis. And this is the laparoscopy finding in this particular case. Uterus normal in contour dimension, UV space normal, POD obliterated, bilateral ovarian cysts around 6 to 8 centimeter with extension, adherent posterior surface of the uterus, the ovarian fossa, and you can see the picture here. You can see the picture here and the video here. This is the situation. When we put it the scope, uterus is enlarged, there is adenomyosis, and because of the previous surgery, because of the extent of the lesion, and see the jelly which is there, and POD is completely obliterated, grade 4 endometriosis. We can't see anything, neither the adnexa can be clearly visualized for that. So at first, to do a good surveillance of this, surgical surveillance, to find out which part is there, what are the structures that are identifiable, and what is the safety area, so that you can dissect. And then you start dissecting with a very, very precaution, taking precaution to the bowel. This is very important, that the bowel is most important, the adjacent gut, and then the rectosigmoid, all are important for that. So always the rule is that you find a good surgical cleavage and go laterally. You go laterally rather than medially. Remember, in endometriosis, go and follow the infundibular pelvic and find it out, and go in that plane for that. Another way, extraperitoneal, you can go it for that, and particularly when there's an extensive disease, and more particularly for the radical procedure of doing a hysterectomy, I think the extraperitoneal can help it, and extraperitoneal can be a better option for that. Same thing in a residual ovarian disease, post hysterectomy, extraperitoneal can be a better help for that, which I've already in my earlier episode I have discussed with that. So this is important, how to have a preventive thing. Now in the rectosigmoid also, go gently, and the resection is either through this, most often I always believe that the suction irrigation cannula is a better dissector for that, so that you can have a suction and irrigation at the same time, so that the clarity of the vision can be there for that. And again, I emphasize the 3D picture for that, and go from the lateral to the medial, not from the medial to the lateral. So this is important. On either side, you just find out what are those, and then you can find the extent of the lesion. The left side lesion here, we cannot distinguish anything about that. The whole ovary and the uterus along with the cyst are adherent. Rectosigmoid is densely fixed to that, but the uterus is not very large. It's moderately enlarged, but at least it's not adenomyotic. The uterus is not very pathological, appears pathological. Now the rectosigmoid has been completely dissected, and this left adnexa Nothing was visualized for that. Then the decision comes. If the right adnexa we find that the normalcy is there, then you can sacrifice the unilateral adnexectomy, because keeping that doesn't have any benefit for that, because we find the tubes, there is a hydrosalpinx, it is engulfed with the ovary for that, and there is a large tube ovarian mass, and along with that it's a previous surgery for that, and we believe that the other healthy ovary, right side healthy ovary and the tube can really suffice it for that. So go through the proper, and this is a infundibule of pelvic ligament. First, you go either you can use the bipolar, you can use the harmonic, you can use the other modalities like the nowadays the CR are available. The CR are very good for that, and you with the simple without any seizure, you can use the seizure which coagulates and cuts it, but a good hemostasis should be maintained for that, and the whole thing serves the purpose of really alleviating the symptoms. The symptoms are relieved to a considerable extent. And this patient, I imagine that the next month she was so happy that she's symptom free for that. That's very important. But I was not happy till after, and the 5th month, I find the pregnancy positivity. I was very happy that this is a very important decision for that. And 25 years young, married 1 year back, with the previous history of laparoscopic surgery. I think these are the cases where the unilateral adnexectomy also can be adopted for that, instead of doing a extensive surgery on both sides. And you just see that these are the cases. Only there is also a cyst in the right side. You can also do a cystectomy, but very, very meticulous cystectomy has to be done, because only one ovary, the ovarian resorb, could be hampered for that. A good hemostatic and to the proper cleavage. This is a cystectomy which traction and counter traction. You just deliver it and go through that. And the least use of the cautery can be used for that. And if you're going through the proper cleavage, I think bleeding will be less, and this can be removed, and that in the proper cleavage for that. So this completes the procedure of that clearance of the POD and restoration of the normal anatomy of the right and ovarian tube. With the unilateral adnexectomy, I think you can achieve a good deal of scientific treatment for the laparoscopic surgery, even in a case of recurrent disease and previous thing. The symptoms will be really symptom free, and pregnancy is warranted. We gave a course of this with a simple course of clomiphene treatment and dufastan. She conceived in the 4th cycle for that. So the message is endometriosis is not uncommon in adolescent girl and a young girl. I married early and about 25 years. Spectrum is variable, presentation is different. Sonography invaluable is a diagnostic modality, but it is not so. We cannot know the extent of the lesion and confirm it. Sonography can say that it's a bilateral ovarian cyst, but on laparoscopy we say that it's a totally a damaged left adnexal region for that. Lap surgery is gold standard therapy. Meticulous surgical technique is a key to success. Adhesion barrier evidence yet to be resolved. Future fertility is a big question mark, but if you're lucky, patient is lucky, gynecologist is lucky, I think the prognosis is much better for that. Now this is a case, 26 years primary infertility, 3.5 years, normal cycle, normal male factor, diagnostic histolaparoscopy was done. Normal hysteroscopy finding, and laparoscopic finding is this laparoscopic finding. Yeah, this is the laparoscopy finding. You can see that uterus is normal, but the right ovary is fixed to the ovarian fossa. Very gentle fixation, and there is a flimsy adhesions and endometric lesion on the posterior surface in the uterosacral with a endometric jelly arising from the right ovarian surface. Now, with that very simple procedure of by the suction irrigation cannula, you can do a good piece of surgery. This is an early endometriosis. And these are the cases where the prognosis is much better, and pregnancy, we expect that this could be a pregnancy for that. But remember, there are many cases of grade 4 endometriosis who conceive after difficult surgery, and immediately after grade 1 surgery also there are some cases which you do not consider. But this is a case where a minimal endometriosis, we can do the justice for that. So concurrent therapy of fulguration is important. Excision I don't recommend unless it's a deep-seated lesion. There are many people, I have seen videos where excision has been done. but the whole thing, excision of the peritoneum deeper into it, and that's very important. But when you are doing a vulguration, see the spatial sites. If it is on the ureter and all that, be very gentle on the vulguration for that also. So there you can do a superficial excision for that. Otherwise, majority of the cases by simple erythrolysis and fulguration, the fertility problem will be over, and that can give rise to a good chance for conception for that. So then para 1, 30 years secondary infertility, 5 years, severe dysmenorrhea, sonographic evidence of endometriosis 10 centimeter. These are all para 1. These are already. And treatment modality, again laparotomy versus again laparoscopy. And on laparoscopy, we find left ovarian tube normal, right ovary chocolate cyst 10 to 12 centimeter diameter, buried with adhesion along with the dilated right tube, adherent to ovarian fossa, uterus suckling posterior surface of the uterus, bilateral free spill of dye present. This is a peculiar situation where endometriosis patency is being restored. Patency is there in spite of all adhesions for that. And these are the surgical planning here. Here, the surgical planning, the sulping over lysis. Yeah, sulping over, these are all endometric tissue, and this is an extra ovarian tissue. When we go for this, just lift the ovary, we find the right adnexa, right adnexa is the large cyst, and this is an extra ovarian because on just dissection, it ruptures at that time of point. So you just do a good sulping over a lysis, and then decide whether you do for a bilateral cystectomy or unilaterally if the left ovarian tube is normal. It's better that you can do a sulping oophorectomy on the disease side for that also. As I have already told, that bilateral is more important. Therefore, when it's a the second infertility, the choice is yours. You can do the, but the good piece of erythrolysis is important, and rectosigmoid could be separated very well and meticulously, and to relieve the pain. This is for relief of the pain. Rectosigmoid has to be separated from the posterior surface of the uterus, and by this blunt dissection and the pressure more towards the uterus, you can really assure that the rectosigmoid is really med free. This is how you just do the dissection in the coming to the lateral aspect. From the lateral to medial, don't go from the medial to lateral. From the lateral to medial, you dissect it. First of all, free the ovary from that. Yes, now it's a free the ovary. Then you think whether you go for a unilateral adnexectomy or for the bilateral cystectomy for that. So these are all atypical presentation and a variable pattern for that, and which is being observed. Now these are all 32 years again, female primary infertility, 10 years, laparotomy for chocolate cyst ovary 8 years back. And laparoscopic surgery, on laparoscopic surgery twice, 6 years and 4 years. Where is the picture? Yeah. And on examination, abdomen scars, BB uterus size not elicited. When we put a laparoscopy, this is the laparoscopy finding. And this because there are 2 times the laparoscopic surgery has been done. The patient is having symptoms. She wants pregnancy. She's married for trying for 10 years. And sonography, we find a big chocolate cyst with the adenomyosis. The uterus is not very much enlarged, but there is everywhere there is adhesion for that. So this initially thinks to be inoperable for a conservative surgery, but we have to do that. And these are all jellies. First of all, foremost is that you go to the right plane of cleavage and take absolute precautions to the vital structures like a gut. So go through the proper cleavage, and that is important particularly, and that's why I told that you go for the 3D laparoscopy for that, and inject the vasopressin on the posterior surface of the uterus, and go to the proper cleavage from lateral to medial, and then do a good sulping ovariolysis for that. So this is what we have done it. And remember again that these are all omentum. There could be the bowel, which is could be adherent for that. Slowly we go to the proper cleavage and around it, and then it can be very well damaged, very well delineated. Now the 2 ovaries which is kissing to each other, the two large ovarian cysts which is kissing to each other. It has now been reflected, and through the from the medial to the lateral, we have gone through that. We cannot identify which one is the ovary. Now after that, we can know that this is the right ovary and this is the left ovary, and the cleavage could be there. Initially it was so joined that we are not able to find out where is the cleavage line for that. And now after that, we go through the proper cleavage from lateral to medial, do a good salpingo-ovarial lysis, and then we go for the separated from the posterior surface of the uterus, the ovaries, and rectosigmoid for that whole thing. The whole ovaries, both the ovaries are fixed to each other, and this is how the spatial plane of cleavage we have got it. And remember that this all vision is important, hemostasis is important, and good cleavage is important for the result for that. So these are the cases. Initially we are thinking that it's inoperable, but in fact after doing the surgery, and we find that this could be operable. And if there's a hemorrhage at a particular point, you have a precise bipolar where you can use that for that. So these are all POD clearance could be there, well done, and the restoration of the anatomy could be there, and then we do the cystectomy for that. And this is a cystectomy, identify the cyst and go through the proper cleavage. Initially, it takes some time, and therefore, once you get a proper cleavage, it's very easy to do the cystectomy, and traction, counter traction could be a really help for that, and that solves the purpose of the laparoscopic surgery. And see how the good cleavage is there, so that with that cleavage you remove that, so the healthy ovarian tissue is being preserved. That is the motto for that. And remember that even residual disease or recurrent disease and repeated surgery can be of help for that, but a good surgical skill is important. The camera, the vision is important for that, and you can do a good piece of job. And I have experienced with this type of patient also, I got a very good result on pregnancy, even seizure, that without any medication also, pregnancy is spontaneous pregnancy can be seen for that. But remember this, that window period is important. After that, window period should be less, and particularly these are the cases 32 years. Give a short trial for that conservation, and then after that you go for the assisted reproductive technology, ART procedures for that. So I feel that this particular case, I am an unlucky patient and unlucky gynecologist. First, next, measure to reduce symptoms, measure to improve fertility, conjunctive versus radical, medical versus surgical, and living endometriosis or living with endometriosis for that. Even with this particular case, at 32 years, 10 years infertility, and repeat surgery, 2 surgeries at the 3rd surgery, and still the patient is so fortunate that the AMH is 3.4. And I'm really hopeful for that this particular case could be pregnant. And in fact, she conceived following IUI on the 3rd sitting for that. And the patient persisted effort, and my luck has been able to serve the purpose for that. Now, this is again a minimal endometriosis, which I have already shown to you. And this is Allen-Master lesion. See, this is an Allen-Master lesion, which is in Allen-Master is a gap in the peritoneum, and that is important. And therefore, and this is again a lesion on the uterosacral. This is a lesion on the uterosacral. This is a lesion on the uterosacral, and this is on the peritoneal surface for that. This is the peritoneal surface lesion. This is lesion for the uterosacral, and this is a surface lesion for that. So then we come to the atypical endometriosis. In atypical endometriosis, we'll find this is a case where we find the uterus is enlarged, but the posteriorly where we expect that the pregnancy, the lesion should be posterior, absolutely normal. Uterus over is absolutely normal, and there is no evidence of even surface endometriotic in the POD. But here you find the uterovesical pouch. You can see that the uterovesical pouch, there is a dense adhesions for that. I have seen a couple of cases where it has invaded to the bladder, and on cystoscopy, they give rise to hematuria. On cystoscopy, endometriotic lesion can be seen, and we plan for a partial cystectomy and the patient is absolutely all right. There is no place for medical management. Surgery is the main thing for that. But here, if the symptoms are not there, only this type of lesion doesn't require any symptom for that. But here the patient is presenting with pain abdomen and adenomyosis is there, and you just encourage pregnancy for that. There is a cyst, fimbrial cyst, which you remove it. This is not for the purpose, but if you do not remove this, this will confuse in further follicular study, and that's why that is the purpose for which we want to remove this. Now this is again a case where this is adenomyoma, localized adenomyoma, but localized adenomyoma is there, and these are all lesions where the tubes are free, and localized adenomyoma, small adenomyoma, doesn't require any treatment for that. And this is another case where it is an upper abdomen lesion. When I see that, ultrasound also sees that there is a cyst in the upper abdomen, and this is a case where the upper abdomen, at the level of the upper abdomen, supraumbilically, we find that there is a cyst which is there, and I just dissected that cyst and find out with the grasper, with this grasper, and the patient, there is an endometric lesion in the pelvis also. By sonography we find it, but apart from it, the sonography in upper abdomen, they found that there's a chocolate cyst in the upper abdomen of about 10 centimeter diameter. I was little confused that there is a pelvic disease. They assumed that is an adenomyosis, irregular size of the uterus, and but here I find that there is a cyst. There is a big cyst of about 10 centimeter arising from the this just with a simple stroke that can be removed with the bipolar, and this is the cyst which I have displaced it to the pelvis. And the pelvis, there is a disease, there is a myoma, there is an adenomyoma, and POD is obliterated, and the POD is the rectosigmoid is fixed to this uterus, posterior surface of the uterus. With the right side, there is a big ovarian cyst for that. So this is to show that apart from it, there could be atypical lesions for that, and that one must be very cautious about it. This is another atypical endometriosis. Can you see that the endometriosis lesion is in the left round ligament? It is absolutely in the case of doing a diagnostic histoolaparoscopy in infertility. This was the finding. It is not creating any problem. It's purely asymptomatic, but this could be a atypical lesion on the anterior segment. So basically we find that endometriosis can be a whole disease process. It can be anything else. The commonest is on a posterior part in the POD, but it's not restricted to only one particular aspect. This is another case where we find this is a case of post hysterectomy. Hysterectomy has been done, and after 5 months of hysterectomy, laparotomy, hysterectomy has been done, but the two ovaries are left behind, and the patient presented with dysmenorrhea, with the bleeding. And when we put a speculum, we find in the vault there are two things. I think I was confused with that, whether it's a malignant disease or residual endometritic disease. On sonography, we find the ovaries are enlarged, a chocolate cyst is there, and they are adherent to the deeper structures in the pelvis on the two ends. And this is the finding on putting a speculum, that this is endometriotic lesion in the vault. And peculiarly, there is a very important thing, this decision whether do a surgery. What surgery you can do it in that particular case? You have to do a partial upper vaginectomy and then only resect it, taking help of the colorectal surgeon for that. But I felt that yes, if there is a lesion, small lesion in the ovary, a chocolate cyst, residual ovary, I put a scope, I find that there is a residual ovary, but residual ovary is cystic endometritic cyst, but it is very small. It's not very large, about less than 5 centimeter on either side. So I removed it. Laparoscopic oophorectomy, bilateral oophorectomy, I did it, and subsequently the patient, after 3 months, I find that the whole lesion has been vanished for that. So this could be one of the factor that you need not go for an extensive surgery of dissection of the removal of the vagina. You do the source of human hormone production. I think that is the main key message which I want to give it. Now, this is a case which presented to me. This is a case of severe pain abdomen. Patient presented with acute abdomen, and when I find that the acute abdomen, whole thing is full with fluid, and I thought that it could be an ectopic pregnancy. Beta HCG was a non-pregnant range, and therefore I thought that it cannot be an ectopic. But sonography says that there is a right adnexal cyst also, so that led to me with the view that it could be a rupture endometriotic cyst for that. And therefore, when I put a scope, I find the whole abdomen and pelvis is filled with cherry colored fluid, and on the right side the ovarian cyst is there. You just go do a good lavage with this endometriotic cyst rupture, and it's an acute emergency. And these are endometriotic cyst on rupture gives a terrible pain abdomen. Patient is not responding to any form of analgesics for that, and therefore a laparoscopy procedure on emergency was being planned. And a good peritoneal toileting is necessary for that, along with the procedure which I have shown you. The same, cystectomy, ovarian cystectomy, restoration of the anatomy, and erythrolysis can serve the purpose for that. So this is one example where I show that endometriotic cyst rupture can be one of the presenting feature giving rise to the acute abdomen. So see, the endometriotic cyst rupture, which has really given rise to this. Whole abdomen is filled with there's a large endometriotic cyst, but the whole abdomen is filled with the endometriotic. So good peritoneal toileting is important, and because it was about 48 hours, how it is pasted to the upper abdomen and peritoneum, you just clean it as far as possible. But I don't know whether you can completely clean. But a thorough peritoneal toileting is essential, and after doing a toileting, you can find the endometriotic cyst and go on with the same procedure of doing a cystectomy. Erythrolysis will all. See, this is a picture which can really present with the acute emergency, and the laparoscopic approach could be very well appreciated for that. Now, this is a case where they presented with ectopic pregnancy, and the typical beta HCG is raised, and on examination I find that they left adnexal mass, and when I put the scope on laparoscopy, I find that the left ovary is fixed to the ovarian fossa, and the tube is really kinked with that. And then I thought that even if the tube are free, the kinking of the ovary and distortion of the ovarian and distortion of the tube can give rise to the ectopic pregnancy, which you can find the ampullary pregnancies there. So I did a salpingo ovariolysis, and then restoration of the anatomy could be there. You can see the corpus luteum on the left ovary for that, and then at the same time did the procedure of the linear salpingotomy and conservation of the tube for that. So this is all about endometriosis with ectopic pregnancy. Now, endometriosis with pregnancy. There is one case who presented with pregnancy, and this particular case, she has conceived following infertility investigation, and she is about 10 weeks pregnancy. She presented with acute pain, and when I find that there is an acute pain, intrauterine pregnancy of 10.4 weeks was there, but there is a right adnexal lump. So that I got a suspicion that it could be patient was having a excruciating pain abdomen, not relieved with any medication for that. So when I find a right adnexal cystic lesion, the question of beta HCG is not going to help in this particular case, because there is already pregnancy there. So only possibility I thought that it could be a heterotopic pregnancy, but the heterotopic pregnancy, I couldn't find anything evidence of the cardiac activity or the gestational sac or any sonographic pointers for that. So I started with the conservative management. The conservative management went on for 2 days, and after 2 days of therapy, the patient didn't improve on that. So the next thing I thought that it could be an ovarian torsion for that, the torsion ovary or a heterotopic pregnancy. So the laparoscopy, gently, this is very important. We cannot put a manipulation for that. and on laparoscopy, I find that right TO mass and right chocolate cyst of ovary is there. And I did the same thing, the chocolate cystectomy. The cystectomy, I did it. And then toileting, peritoneal toileting, and pregnancy, continuation of the pregnancy could be there for that. And these two possibilities, you remember heterotopic pregnancy or a torsion ovarian in pregnancy in this particular case when we deal with that. Now, this is a case of, again, endometriosis and myoma are coexistent in quite good number of cases. This is a case of endometriosis with myoma. This is, initially I was thinking that it could be an intra-ovarian lesion. It appears to be an intra-ovarian lesion without any peri-ovarian adhesions, but the ovary is fixed to the ovarian fossa. I drained, initially put a drain into it. The total trocar, you big cyst, you introduce a total trocar into it, so that the unnecessary spoiling will not be there. So you do a cyst irrigation completely with this method, so that the soiling will not be there unnecessarily. And this is a procedure when we always do in large cyst for that, chocolate cyst for that. So after that, you do assess the adhesions for that and do a adhesiolysis. You can see it still we find the chocolate colored contents with that, and there is still the upper part is fixed to the posterior surface of the uterus, and a good lavage is therefore necessary for that. So reach the ovarian cyst with that, and then do a planning for a cystectomy. And along with that, we do a lap myomectomy. Along with that, I've done the procedure of lap myomectomy with cystectomy. It's a large ovarian cyst with adhesions on the POD, as I have noticed that. The other side ovarian tube is normal, and good dissection is important. It's a big cyst, good dissection. The other side tube is thin, the femoral end is thin. The ovary is yet to be seen for that. We try to negotiate, we try to separate it from that. And now I find that yes, this is the cleavage where the two things, the left ovary is just separated from the right side, and then the cyst wall, cyst is very well seen for that. Identifying the cyst wall, you just do a cystectomy and then do a myomectomy for that. And this is a procedure which a concurrent myomectomy with the cystectomy has been done. And big cyst, what we do a enlarged cyst. Instead of doing a cystectomy, we do a partial oophorectomy. You remove such a big cyst, cannot be to do a cystectomy is a hell of an affair for that. So in large cyst, we always this is another technique where you do a partial cystectomy, so that the rest of the tube, rest of the cyst can be minimized to a considerable size, so that cystectomy can be much better can be done with much ease for that. So this is what we did it with that, and the partial cystectomy, partial oophorectomy. I think the cyst wall along with the healthy tissue is now removed. Now you can find that this is the ovary, this is the rest of the ovary which is there, and it is very easier to remove that. This is the technique for a large ovarian, very large ovarian cyst, where to do a cystectomy is a hell of a affair for that, and surgically it's not very much recommended and possible also. It's not required also for that. And therefore, now after that, you go to the proper cleavage, and the size is now less, and you can do the good cystectomy with the proper cleavage, so that the pregnancy can be achieved with that. So this is how in large ovarian cyst we do the procedure. There is no harm in doing removing the extra ovarian tissue, even if it's a healthy ovarian tissue. Some of the healthy ovarian tissue can be there, but quite good number of the proportion of the healthy ovarian tissue is more kept behind and reserved for that. And then the whole of the cyst wall can be really better tackled with that, instead of doing a cystectomy, taking a lot of time, and really it's difficult also. Surgically, it's difficult to do the procedure in a very large ovarian cyst of about 20 centimeter or 30 centimeters. Such large cases are there also. So these are the cases, and this I was telling that a good surgical cleavage and hemostasis is important. Whenever you find active bleeding, you have a precise bipolar coagulation and arrest the bleeding at that particular moment for that. And And here is a case where there's not much of bleeding, but still that can be coagulated with a least current, and whole cyst wall can be enucleated, keeping the healthy ovarian tissue intact for that. That completes the procedure. So in two-stage procedure, I have done it. I have removed part of the ovary along with the cyst, the major chunk, and the rest 25 to 30% of the ovary cystectomy can be done, so that the reconstitution ovary could be appearing as a normal ovary for that. And then the same sitting, you can do a myomectomy, and this is a procedure where the myomectomy and ovarian cystectomy can be done. And here there is small amount of bleeding here. You can just do a coagulation at the edge, and you see, identify that where is the site, and don't do unnecessary fulguration to damage the ovary for that. And the hilum, you just restrict for that. Otherwise, this is a small, very special precaution at the level of the hymen. Don't use just little coagulation to arrest the bleeding for that. And then subsequently do a rest of the procedure of adhesiolysis, separation of the rectosigmoid from the posterior surface of the uterus, and complete the procedure for that. And this is important for that. And the same sitting, you can do a myomectomy also. And here I have done the same procedure of myomectomy in the same procedure, which in myomectomy I have already shown this, but this could be a additional procedure for that. And this is, and while doing the two important things, coagulation at the level of the hilum and coagulation near the tube, you just restrict it. And these are all endometric lesions, surface endometric lesion on the uterus, which has to be coagulated for that. And this is just for experiment. I don't go suture it much, but it's because the suture, I have sutured the uterus. You can see the myomectomy, after myomectomy, the barbed suture for that. And this particular case, the suture is not necessary. If we leave it as such, there is not a problem. But I just seen a comparison between the suture and non-suture, and to oppose the age, I put a one suture for that along with the myomectomy suture for that. And this is again a large chocolate cyst, about 28 week size, power abdomen cystic lump, and it's a chocolate cyst. It's not a power ovarian cyst, as I've already told you last time and shown you the slides, but this is a chocolate cyst. Again, the same procedure as in the previous case. Such a large ovarian cyst, you just do a irrigation to avoid unnecessary soiling of the peritoneal cavity, and after irrigation, then you remove part of the ovary with the cyst for that, and that is essential, rather than doing a cystectomy, taking really a surgical expertise and a challenge for that. And this is important, that you just do a thorough lavage for that and start at that particular. So wherever you start the taking precaution about the hilum, taking precaution about the tubal side, you select an area where you can do an excision for that. So the excision of the ovary you do in a particular site, keeping the healthy ovarian tissue, and this is how major ovarian tissue, about 70% of these tissues can be removed, excised, and the rest 30% you can do after the procedure is over. You do a cystectomy. This is the same thing which I have done, shown you in the last case for that. Now this is again another case where is a case where she has completed the family para 2, having a severe pain abdomen and dysmenorrhea. When I find a large adnexal mixed echogenic lesion, solid cystic area on the left adnexa, and uterus is normal, and color Doppler shows that it is avascular. So I ruled out this, and this is the right side tube and ovary, which is absolutely normal. And patient 40 tissue is not there. The only thing is that excruciating pain, dysmenorrhea, and all that. Same thing I told, that nothing could be recognized. The whole tube, the left tube and the ovary is forming one mass for that, and adherent to the adjacent structures. So the best treatment could be a sulping oophorectomy. So left sulping oophorectomy, do the procedure, and the patient will be absolutely all right for that. And this can be done easily with the laparoscopic procedure, and with the very easy procedure which an average gynecologist can perform this for that. And this dissection and decision is important, as I've already told, and therefore this is a case where It needs an attention for that. So you decide according to the laparoscopic finding, where sonography cannot give a guideline for that or treatment. So laparoscopic, diagnostic laparoscopy, and then proceed could be an answer for that. But a very good dissection and a meticulous dissection and preservation, separation from the gut is important, because the gut is so close to that mass that you have to do a good erythrolysis for that. Always go from the lateral to the medial, as I've already told. And my best instrument is a suction irrigation cannula. I just depend on that, and that is my great asset as a hand instrument for that. And the whole thing can be dissected very well. And after doing a proper salping ovariolysis or separation from the adjacent tissues, it's very easy to remove the tissues for that. And laparoscopy procedure can be much better with this left tiomas, and the patient is relieved of all the symptoms for that and patient. And because the right ovary is absolutely normal, she is already paras with 2 babies. She doesn't need a baby, but mainly relief of the symptoms should be there for that. Now, this is again an interesting case which I have done the chocolate cyst primary surgery procedure, and 5 months after, she presented again with the cyst. So I was a little worried that after 5 months, it is a recurrence, and ultrasound shows that about 15 to 20 centimeter cystic lesion in the pouch of Douglas for that, and more towards the left side. And I did the left cystectomy earlier, about 5 months before. So when I put on ultrasound revealed that there is a, it's not a echogenic contents, it's a relatively clear. So the point comes to my mind thinking that it could be a pseudocyst. So I put a laparoscopy, and a patient was asymptomatic. Patient doesn't have any pain, but the sonographic findings has confused us, and really she was also worried, and I was also worried for that. So when I put a scope, then I find that it is a pseudocyst, and adherent to the intestines, adherent to the adjacent structures. So I went to the proper cleavage and see the whole of the POD. There is a multiple septa of pseudocyst, and this is the left ovary, and the left ovary which is there, and this is the left ovary which is normal, and there is a pseudocyst completely in the pouch of Douglas for that. So that is also a possibility, that pseudocyst could be a possibility. Think of it, and sonography will identify the echogenic contents. The recurrent disease could be completely different, because the echogenic contents could be another lesion of the endometric lesion of anechoic area, the echogenic pseudos, but here completely anechoic areas will be pointing towards the pseudocyst for that. So this is one of the possibility. You must think that pseudocyst could be there, and you cannot say that which case go for pseudocyst for that, because there could be on erythrolysis initial surgery. It appeared after 5 months, and I pray God that next time it doesn't come again with another pseudocyst. So these are the areas where is important for that. Now, this is related to the scar endometriosis. I have a number of cases of scar. I'm very fortunate to get good number of scar endometriosis. I don't know where from they come, but I'm very happy that scar endometriosis. This is a scar, Caesarean scar has been done, and typical cyclic pain. Typical cyclic pain at the angle of the scar, and it was not relieved with any form of medications. Even GnRH analog it was given, even Dynogest given, but it was not being relieved for that. And sonography also see that there is a parietal swelling and a parietal lump of mixed echogenic area. So this particular case is not amenable for medical management, and it's very easy that extent of the scar endometriosis should be there. Where is the lower limit for that? Whether it is above the rectus sheath or below the rectus sheath, or attached to the uterus, or there is a uterus or ovarian disease along with that. That is very important for that. So on dissection we can find, and at the end of the dissection we can say that where is the upper end, the lower end of the extension of the disease, whether it is above or below. So go through that proper cleavage and a wide margin of this with the good hemostasis. You go and dissect the all around, dissect the tissues all around and find out where from it is there. And healthy tissues you take a margin of the, otherwise it will be again a recurrence of the lesion. Wide margin of the tissues, taking a healthy tissues also along with these is important for that. And therefore, step by step in all areas, you go gently and to find out where is from that. And this is not a very difficult surgery, but quite some, in some individuals that could be found out for that. The cause we do not know why this occurs, whether the endometrium or immature endometrium in hysterectomy, or a mature endometrium or a decidua in post delivery occurs for that, but it is not certain for that. But you see, this is a very easy surgery. It's not a very difficult surgery, but and the diagnosis is also very easy, because it gives rise to a really a cyclic pain. And this is important, that when it is involving the rectus sheath, then it is extension of the rectus sheath is there, then a position of the rectus sheath is not there, then you have to use the mesh for that, mesh plastic for repair. Otherwise, anatomical repair can be very well for that. So here is a case where the anatomical repair is sufficient. We didn't need a mesh for that. And you can find that this is a rectus sheath. You can find that this is a rectus sheath, is up to the rectus sheath. The lesion is extended for that. And going through the proper cleavage all around with the hemostasis, maintenance of the hemostasis, you can find that this could be the real solution for that. And you see that this is a case where, yes, rectus sheath, this is the rectus sheath. It is rightly up to the rectus sheath. It has not gone in the muscle for that. And this dissection can really tell you where is the extension of the lesion. This is the muscle which is there, and above the rectus, above the muscle. And here we can find all around, and whole endometric scar tissue could be excised for that. And then you close it for that. But the only thing is that why it occurred, we do not know the cause of that. You send it for confirmation of the biopsy. If you cut it, you can find a good typical scar endometriosis could be there. You can find the typical lesion of the endometriosis on gross appearance, on incision of the scar. The tissues, you can find the clear evidence, and you can diagnose it self-evident for that. And this is the tissue, endometric tissue. So wide excision is there, good hemostasis and a closure can serve the purpose for that. This is another case, which in my case, I done a endometric tissue, endometric surgery by laparoscopy, and the patient presented with about 8 months after the surgery, she presented with typical cyclic pain on the port site. And on the port side, when we find that there is a typical thing, I thought that it could be a port endometriosis. The sonography confirmed that it's a mixed echogenic areas in the subcutaneous tissue, in the parietal tissues. And then I thought, what is there? So I planned it for local excision along with the diagnostic laparoscopy to find what is there inside, whether, because the ultrasound doesn't reveal anything abnormal in the uterus or ovary. It's absolutely normal, but there is a sport endometriosis. So you just find out that this is a case where it can be enucleated very well for that, but it has not gone up to the level of the peritoneum. So I did it a diagnostic lab along with that sitting, and diagnostic lab, you can find the diagnostic lab. There is absolutely normal uterus and ovary, and the port site is absolutely normal, and therefore just you close this, and that gives a lesson to me that since that time I was just retrieving the tissue through the lateral port and blindly removing the lateral port. And from that time onwards, I stopped the position. I didn't receive the lateral port and all that. I always go for the lap sac to remove the port, or through the 10 mm or 10 mm port, or with the, if I'm using the morcellator, I use it, but it should not touch the port site. And that is a lesson that to everybody, all of you, don't retrieve the endometric tissues or the dermoid blindly through the port for that. You can retrieve it through the pouch of Douglas for that, but don't do it under the blindly through the extension of the lateral port for that. You can use with the cover of the 10 mm port, reduce the mass and deliver it for that. Now, this is another case where typically the patient presented with swelling of the umbilicus and pain, cyclic pain, and bleeding from the umbilicus every month. Is a typical of umbilical endometriosis, and there again the chances is that you find that on ultrasound we didn't find any evidence of any pelvic lesion, and there I planned for the umbilical excision of the endometrial tissue where we cannot preserve the texture of the umbilicus. We have to go for an omphalectomy for that, and again we go for the right up to the extension of the lesion, and the extension of the lesion is right up to the level of the, because all the layers are fused to the peritoneum, it has to go to the peritoneum for that, and therefore the whole thing can be excised. This is the thing you can see, the whole thing can be excised. And after the peritoneum, when I find that this the peritoneum is there, then I found that, then I put a scope and found out that whether there is any other lesion in the pelvis for that. So there is no lesion in the pelvis, only restricted to the umbilicus, but such things can happen, umbilical endometriosis. And you can see that this is a large lesion on the endometriosis lesion, superficial lesion appears very small, but deeper. It's very important that it's a classical example of this, because we do not know why the endometrial tissue are so inclined to the endometriosis for that. So this is an area after surgery, after removal, the whole thing, you can inspect it through the port and the other abdominal pelvic area, and closure in layers can suffice it for that. Now this is another case where a perineal endometriosis. You see, this is a case where a perineal endometriosis, the patient presented with severe dyspareunia, is not able to do, I think, have a intercourse for that. And unfortunately, I find above the fortuity, I find a typical thing, which is really the patient presented that every month I used to have a bleeding, but is not able to say where from the bleeding occurs. But the pain, because it's confused with the menses, but the pain is tremendous inside in the fortuity area, and all the time I have a dyspareunia for that. So this is a case again where a gentle, very gentle thing has to be done for that, and excision of the tissues well above the rectum, very important. You don't injure the rectum, but take special precaution and a wide margin, taking a healthy ovarian, healthy tissues all around in the vagina. You just do it and remove this. So perineal endometriosis is also, rather it's a vaginal endometriosis and the fortuity. Normally, we do not know. Every month the menses occurs and there is an implant, but all cases do not go for that. The cause is not known for that. These are all endometric lesion, and gradually with a saving technique, I did it. And this is the rectum, putting a finger in the rectum and filling it. I just excised all around, because otherwise again it will recur for that. And then I reconstructed the tissues for that, and that finishes the whole of the tissues of the vaginal endometriosis for that. This is another case where it's a classical perineal endometriosis, where there is a swelling and cyclic pain in the right vulva region in the perineum. You can see that there is a lesion of about 4 to 5 centimeter, and here the question of excision again is a major thing for that. It doesn't respond to any form of medical management, and again a wide excision has to be done, and otherwise it will have a, if you leave something, a small tissue, it will again grow under the influence of the hormones, and that creates a lot of problem for that. So this is a case where go through the proper cleavage again, and all around go slowly, have a wide margin of taking a healthy tissues. You just remove it, and then it is typically in the ischiorectal fossa, and you can just have a wide excision. Not much of skill is necessary, but the very important thing, care to the rectum on one side has to be done. Bleeding at times has to be controlled, because there could be vessels which bleeds unnecessarily, but taking a healthy tissues also around a wide margin is important, because there is, in order to reduce the chance of recurrence for that. And that completes the procedure of the ischiorectal endometriosis or perineal endometriosis. You cut it, and then this is a typical example, typical finding of the endometriotic tissues, which then confirms it by the histopathologist for that. And just appose it and reconstruct it, and like an episiotomy, and you can do the job. Complete the obliteration of the dead space and hemostasis, and the patient can be discharged the next day onwards for that. So perineal endometriosis. Now this is a case again. This is a case of severe pain abdomen, dysmenorrhea, uterus is enlarged up to 12 weeks. It is a localized adenomyoma, and MRI confirmed that it is a localized adenomyoma. She is infertile, but the main problem is pain abdomen. And peculiarly, this pain abdomen is not amenable to any form of medical management for that. So I planned for adenomyomectomy. Remember, adenomyomectomy in a localized adenomyoma, not in a diffuse adenomyoma. And localized adenomyosis is a difficult thing. Myomectomy is a difficult thing. You just have a major portion of the adenomyomatous tissue excised. And remember the line of incision. It's a different type of line of incision you give. You give in a garter-shaped manner so that the inner part will be really more than the outer part for that. So that the stitch or the suturing will be much better fitted for that. So you take an incision in such a way that it could be really the upper part and the lower part, there is a different level for that. Don't take it in a same level, and the whole and adenomyoma can be removed for that. And you, as you go on and on, you can find the extent of the lesion of adenomyosis, and you can enlarge it and a little go beyond that also. But give a vasopressin, same thing as the myoma, so that the bleeding will be less. But the main problem occur with the stitching, suturing. So that's why if your incision is very important, incision is not straight, incision is little, I think, deeper inside, I think it can be opposed very well. The lower part and the upper part should be in a different plane for that. And I'm using this, the same vicryl, this quill suture, barb suture, and barb suture is much more better in this particular case. And I did this, complete the procedure, patient is absolutely pain-free, and she conceived also following that. So these are rare cases where this can be giving a really a good picture for that. Now, when this patient attended, the age fertility is over, or she is waste with the fertility treatment gone, but still the pregnancy is not achieved, reaching 40 or beyond that, and the pain for the pain and bleeding and all that, we need a procedure of more radical rather than the conservative. So these are 4 cases of hysterectomy which I am showing you. This is one case where this is associated with also the sonographic appearance also, along with the scar endometriosis. There are some endometric lesion in the uterus for that. So this is a case where we plan for the procedure of excision of that along with hysterectomy. So these are the cases where after the procedure is over, then you can know what is the extent of the lesion and the need for the repair, whether it's anatomical repair or a mesh plastic for that. And that is very important. And when you find that there is a lesion, this is a case where is a completely the whole endometriotic scar endometriosis lesion is adherent to the uterus. We find that this is a lesion which is adherent to the uterus. It's right up to the uterus, and therefore hysterectomy is planned along with that. And it's a difficult hysterectomy because conventional also, we find that if there is a previous surgery, repeated surgery, and there is a adhesion of the uterus to the rectosigmoid and ureter, it's a really a difficult surgery. Finding a good cleavage point and a safety point is important. More towards the uterus you go, and then do the procedure for that. And the whole thing is you have a healthy margin also, you take it. Otherwise, again, there will be recurrence of the scar endometriosis. So this is a difficult case where scar endometriosis is, along with that, we find that the uterus is diseased and there is a grade for endometriosis for that. So a conventional, it cannot be amenable for laparoscopic procedure, so that we have to go for the conventional laparotomy. And for that, even for conventional laparotomy, it becomes a risky procedure unless you go for the safety cleavage for that. So this is how you just excise you identify the whole bulk of the scar endometriosis, and then go through the proper cleavage and take a healthy margin for that. And then you can find that, yes, we have reached the uterus, and the uterus completely can be delivered for that. And here the main important is that the total anatomy is being disturbed by the previous surgery, and therefore it's very difficult to have even if a conventional, uh, it's very difficult to protect the gallbladder, protect the rectosigmoid and the ureter. But the main key is that go closer to the uterus. That is the key when you adopt it. I think that can be the really success for all this. So when I find that this is the rectus sheath, the rectus sheath all around, we dissect it, and it is fixed to the rectus sheath. I was thinking that it is a fixed to the rectus sheath for that. But when I gave an incision on that, I could find that yes, the whole of the uterus, the fundus, was adherent to the upper abdomen and to the scar and to the endometric tissue for that. So here, along with that, we have to remove the whole of the uterus along with the ovaries, and taking due precaution to the rectosigmoid for that. So this is how you go for that. And again, hemostasis is a major factor. You go to the proper hemostasis, and with the cat's paw, with the proper cleavage, you find out the line of cleavage for that, and then you enter into the abdominal cavity and find out what is there inside. So this happens in a repeated surgery, and very skilled surgeon is required. Even if conventional has to be done, skilled surgeon is required to deal with this situation for that. All around, this is a rectus sheath where I've incised it all around, and then gone through that, identifying where it is at the other end, and opening the uterine, opening the peritoneum. And after opening the peritoneum, then only I can know that what is there inside, particularly whether the condition of the uterus, the ovary, and other pelvic structures for that. So there is no question, there is no place for laparoscopic surgery here in this particular case, and one has to go for laparotomy for that. So the era of laparoscopy, when it's come, you say that the era of laparotomy is gone. I don't believe in that. There is some place where there should not be in dogma in science, and there is a place where you can go and treat this particular individual according to the need of the patient, not the mood of the gynecologist, and not to show your exercise for laparoscopic techniques and surgical endeavor for that. It's always for the betterment of the patient and safety of the patient first. And that is why you go along with that. And still we are not able to enter into the abdominal cavity, peritoneum, with very meticulous techniques. You enter into it, gradually going and dissecting all around. You enter into it and then do the procedure. And now you have to be very, very clear, very, very meticulous in this technique for that. Every surgery you do a meticulous procedure, but in a conventional procedure also, with this type of cases, it's not very easy. You say that you open it and laparoscopic surgery is difficult, and this is easier. I don't think that this is easier for that. And therefore, the cases, I think senior gynecologists should come in, and a good amount of training has to be done, particularly for this type of recurrent disease and recurrent cases of endometriosis. And therefore, I always say that endometriosis disease, even if radical, conservative is difficult, but even if radical also, repeated surgery creates a lot of problem for that. And whole thing, I think whole uterus is fixed. Now you can see the uterus fixed to this scar endometriosis. And this is a procedure where this is the fixed to the scar endometriosis, and the whole endometriosis, scar endometriosis is over. Now the uterus has to be removed with that, and therefore after cutting confirmation of this, that you go and find out the uterus and remove this with the good cleavage for that, and that completes the procedure of abdominal hysterectomy in a endometriosis for that. Now this is a case again, we're going for a total laparoscopic hysterectomy, TLH, with the harmonic procedure, and this is easier. This is somewhat the left ovary is little free, but there is an endometriosis in the POD, and POD is obliterated, and we are going for a laparoscopic total laparoscopic TLH procedure in this. You can see the endometriotic lesion as we go down and down, and the POD is completely obliterated with that, and the other side also the same procedure we do that, and the same technique of doing this TLH either by the bipolar or by shear or by harmonic, you can do the procedure. Now here again it's a laparoscopic procedure where hysterectomy has been done. The whole ovary is adherent to this, left ovary is adherent to the ovarian fossa, but it's not a very difficult procedure for that, and it can be because it can be really dissected. But the POD is completely obliterated. You can see the rectosigmoid adherent to the POD, and the left ovary and the right ovary and right adnex are completely adherent for that. And first and foremost is the finding out the separation of the adnexa from the adjacent structure, and after the adnexa are being cleared, the POD has been POD lifted, and clearance of this and rectosigmoid could be there. The right side big endometriotic cyst is there, and you just collapse it and find it out, so that things becomes easier for that. So this is the classical example and indication of lap hysterectomy, where this is cannot be this is an alternative to abdominal, and really these are the cases where earlier laparotomy was being done conventional, but remember that these are the cases where laparoscopic hysterectomy has a greater advantage because of the minimal invasive nature as well as the possibility. It needs a little amount of skill, but still it is important because it's a minimal invasive surgery and you can do the procedure. And vaginal hysterectomy in this particular case is contraindicated. When you find that laparoscopy, the patient is presenting pain abdomen, and there is a ultrasound evidence of ectopy, the endometriotic cyst, I think put a scope rather than have a dogma in doing a vaginal hysterectomy. This could be possible. Vaginal hysterectomy, expert vaginal surgeons can do it, but I think it's much better to do a lap hysterectomy in this particular situation for that. And this is another case where it was not known. It is a plan for vaginal hysterectomy, but during the procedure, I find that the POD is completely obliterated and there are endometriotic lesions. The whole uterus is fixed to the rectosigmoid. So there was no way out that I can, instead of converting it, I did this with this vaginal hysterectomy with this procedure. And here, if you go through the closer to the uterus, again the same philosophy. You go closer to the uterus and you don't open the, it's difficult to open the POD. So don't open the P pouch for that. Go closer to the uterus, and P pouch cannot be seen because it's completely adherent right up to the fundus. And UV space can be open for that, but don't wait for the UV space to open. Normally go closer, put a clamp on either side, and I'm doing a sutureless hysterectomy, and that things will be all right if you go for that. And even the ovarian removal, ovary is fixed to the lateral pelvic wall, and even if there is a cyst found, and we can deliver it by the vaginal hysterectomy. So this is how you go closer to the uterus. Don't try to open up the POD. You are opening, if you try unnecessarily, your likelihood of opening the rectum. So closer to the uterus, and gradually you go, and after uterosacral and the Mechendorf, things will come out and uterus will descend, and you find a good space for that, and then you find a space for that, and now you can find that yes, whole uterus can be out for that. So now the uterine artery, this is a vaginal hysterectomy in an unknown cases, undiagnosed case for that. So even if you find that undiagnosed case, vaginal hysterectomy can be possible, but knowing fully well that it's a case of endometriosis, don't attempt this vaginal hysterectomy. Even if you are an expert for that, that's my message to all of you for that. And if the patient is presenting with pain abdomen, I think put a scope to find out the nature of the pain, why the pain is there for that. And you can deliver the ovary and all that, but exceptional circumstances when you are not sure that it could be there, and on intraoperatively you find that there is a lesion, there is an adhesion, and there is an endometriosis, you proceed. Don't go for a conversion unless it is indicated for that. And skilled vaginal surgeons can do the procedure with a good satisfaction, so that this is a case where the uterus adenomyosis is there. So adenomyosis, the bisection, you do a bisection and do a debulking and then complete the procedure for that. And although the sonography says that it is an adenomyosis and the uterus is enlarged, but the size of the uterus doesn't determine the nature of surgery, whether to convert it into laparoscopy. But the pain is a predominant finding. If the pain is there and pain other than the menses is there, I think it's better that you just rule out the cause of pain, and for the diagnostic purpose you do it. And debulking and internal coring is going to help in the solution of this particular case. And after the procedure is over, the ovary can be easily removed for that. There is an apprehension that ovary cannot be relieved, cannot be delivered for that. But believe me, ovary can be also big, large ovarian cyst can also be enucleated. And if the ovary is pasted to the lateral pelvic wall, I think with the finger dissection, you can find it out after removal of the ovary, after removal of the uterus completely. Then you go for the procedure so that you get a space, and you get a space for this removal. And I always prefer to have the sutureless and applying the bipolar, and lot of newer bipolar have been found. A SEER system is there, but main thing is debulking the procedure. You debulk it and then do the procedure so that the safety is there. Because it's a case of adenomyosis, a big uterus of about 14-week size. So thinking that it could be a myoma or adenomyosis of 14-week size, whenever we plan for the vaginal and accidentally we find that there is a adhesion when we cut the post POD, we do not find the P pouch is not open, then we saw that yes, it's a densely adherent to the posterior surface of the uterus. In that situation, again I'm telling you, go closer to the tissue. If you go closer to this tissue, ultimately the point will come at the level of the fundus or gradually below the fundus, the separation will come and things becomes easy for that, as you see now. And the last pedicle, we use it with that clamp so that the bulk is removed. You don't apply that. This is the clamp which is used, but I'm not going to have a suture for that. But removal with the clamp will really give a space, allow a space to find out so that the ovary can be delivered very well for that. So this is the main technique which I always adopt when I remove the ovary. I think clamp in the upper pedicle, not to have a suturing, but to have the space available for that. And that therefore, after the space is there, then you go for the classical salping oophorectomy by just coagulating the round ligament first and then attempt for the infundibular pelvic. One of the very important features in that particular case, you see that you are not going to injure the damage the bowel, particularly for that, so that you keep a gauze piece ready and gauze piece above that. And this is how you use the clamp. This is how you use the bipolar, and after removal and whole of the neck size removed after that. The same thing you do the other procedures and then do the suture and all that and see for the bleeding. If it is not there, then close the vaginal for that. So this is how the procedure of hysterectomy, of the different types of hysterectomy, is being done for that. So my viewers, I've almost completed exactly 2 hours from now onwards. So I say that Sir William Osler has told, he who knows endometriosis knows gynecology. And still today, we do not know the spectrum of endometriosis to such an extent. Even with the advancing knowledge of concept and technology is advancing to a greater extent, the surgical skill also is developing. The new generation are doing a good job for that. And therefore, we find a spectrum of presentation and the definite treatment for that. You are the best judge. I'm just giving a sample of my own experience, sharing to you during the couple of 2 hours. And you are the best judge to improvise, give a comments, and explain when the treatment modality of endometriosis as far as surgery is concerned, how scientific and rational it could be for that. Thank you very much, all of you. And Francis Bacon's statement, I remember, that read not to contradict and confute, not to believe and take for granted, not to find and discourse, but to weigh and consider. So I have given a platform to all of you to weigh and consider, and you are all genius watching my talk and watching and hearing, listening to my talk and watching my videos for that. And this is just a sample and token of sample where I can infuse you and I can stimulate you. Basing on that format, you go and improvise and do more and more, and sky's the limit for the younger generation. Thank you very much, Dr. Diwan and Dr. Mr. Ala.
It was really a wonderful talk, and we all admire the way you teach. You're so engrossed in the whole subject, and it makes the subject so easy to understand, sir. Thank you so much for your delivery.
Thank you.
Sir, there are a few questions if you are ready.
Yeah.
Okay. See, there is Dr. Alkata Das from Bhubaneswar. She's asking, is it possible to diagnose grade 1 or grade 2 endometriosis by MRI?
Well, MRI cannot diagnose grade 1 or grade 2 because surface lesions are very, very difficult for that. I always say that it is a suspicion of grade 1 and grade 2. If there is an adhesions, displacement of the ovary, POD, and many sonologists, radiologists give an opinion, adhesion. Adhesion, how they can diagnose adhesion by that? They can suspect adhesion for that also, but adhesion band cannot be diagnosed with that.
Right, sir. So this is Dr. Poonam Gupta from Varanasi. She's asking if a 34-year P1 with 4 centimeter endometriotic cyst approach of treatment in presence or absence of adenomyosis.
Yeah, if she is concerned about the fertility, second pregnancy, secondary infertility, I think 4 centimeter size. Number 1 is size. Number 2 is extent of adhesion. Adhesion we cannot know, but the size we can know that is a 4 centimeter. So with the 4 centimeter, you can give, you can try for a couple of months for pregnancy, and with the pre-op GnRH analog and Zoladex, you can give it, and ovulation induction, you can do it also. And then I think there is a place for diagnostic and therapeutic laparoscopy after that.
Okay. So Dr. Kavita Babar from Bilaspur, she's asking, many times a cyst wall is not clearly delineated. Does pre-op or post-op Dynagest help?
Dynagest is a drug which relieves the pain. I think that's important. You must understand that the Dynagest is a drug which removes the pain, but the structural or volume reduction is not there with Dynagest. So therefore, the GnRH is the only thing which acts on the local tissues where the reduction will be there. Even if it's a temporary thing, it will reduce it, and that gives a good cleavage for that also. It cannot be with a Dynagest for that.
Right, sir. So this Dr. Mrs. Purnima Nipram from Imphal, she's saying that she has a patient who complains of cyclic swelling and pain in episiotomy scar area. She responds to GnRH analog given 3 doses monthly. She becomes asymptomatic for 6 months. Again, she returns and it reoccurs. Please suggest how to get.
That is a typical case of perineal endometriosis. And remember, I've already told that medical management of these particular cases are all temporary thing. So GnRH analog, if you give it, it can temporarily relieve the symptoms, or Dynagest you can give it, it temporarily relieves the pain. And quite a good number of patients, about more than 50 to 60% of the patients do not respond to the medical management for that. So this is the ultimate solution, that surgery is the main treatment for this perineal endometriosis.
Right, sir. Sir, there is Dr. Shubhra Samantroy from Bhubaneswar asking that when can we go for pregnancy after chocolate cystectomy with multiple myomectomy?
Well, chocolate cystectomy along with the multiple myoma. And what is the type of myoma, whether the cavity is open, whether the cavity is not open, whether you have done a transcervical resection of the myoma hysteroscopically or laparoscopically, that is also a question mark for that. As far as the endometriosis is concerned, I have already told about the window period. The best window period is within 6 months of surgery, six months post-operative. So at best, if she has gone for myomectomy, along with the endometriosis, you give a trial for at least 2 to 3 months, not more than that. Because if you give a more period, what the period is lost, and the chances of conception are reduced for that.
Okay, sir, there is a query from Cuttack, Dr. Manoranjan Mahapatra. She's saying that what's your view on retroperitoneal approach for frozen pelvis?
Yeah, that's what I told, that in frozen pelvis, retroperitoneal is very good And particularly in a case where there is a residual ovarian tumor, retroperitoneal is very good. And if you are going for a lap hysterectomy, I think retroperitoneal is a very good option for that. But for fertility promotion and all that, retroperitoneal doesn't help any help for that. But in exceptional situation, when you are not able to enter into the cleavage, you don't find a cleavage into it, retroperitoneal is the answer for that. And even a hysterectomy, I think I will recommend the retroperitoneal is the first option. And retroperitoneal operation and I think retrograde hysterectomy is the major operation. We have tried that there. It prevents the chances of injury to the rectosigmoid for that. And it becomes very easy if you remove it, retrograde hysterectomy.
Another question from the same person is that what's your view on fulguration of endometriotic spot in pelvic peritoneum versus excision of endometriotic lesion?
Well, and this is a very important question which I see that normally eradication of the tissues excision is conceptualized as the best form of treatment. And I remember in one of the ASRM conference in Baltimore, one surgeon was demonstrating the same thing. Small few powder-borne lesions in the uterosacral and posterior surface of the peritoneum. And he went for excision of that. And at the end of the total peritoneal excision of the whole posterior segment was being done. I apprehend every people, there is a question from all the audience that is it a too much of surgery for too little a disease? So that's the main question for that. But certainly when there is a vulnerable site like ureter and all that, and we find that it could be a deep infiltrative more than 5 centimeter, it is not peeled off well. If it is peeled off well, you can find that is a superficial endometriosis. But if there is a dimping of that and more than 5 millimeter on the vulnerable site, it is better to go for the excision for that instead of just a simple fulguration.
Sir,
but rest of the sites you can fulgurate. There is not a problem. But remember how to prevent. Don't do too much of extensive surgery for that.
Right. Sir, Dr. Aarti Nayak from Bhubaneswar asking that when suturing of ovary is essential after doing cystectomy?
Suturing of ovary is not at all essential for that. In exceptionally large cyst, when the raw area is more, you can suture it for that. I was just shown one case where for sake of debate I demonstrated. I never suture for that. Because in that particular case, I showed that laparoscopy myomectomy along with that raw area to cover. Just to show you the surgical technique, I have shown this suture for that. Otherwise, suturing is not at all recommended unless it's absolutely very large cyst and you have removed it and the raw area is so much exposed after excision of the cyst that it looks odd. Remember, by suturing immediately after surgery, it looks very nice for that. But studies shows that suture or non-suture, the results are all same. Rather with suture, more of adhesions are there for that.
Right. So she's also asking like what drug is ideal for recurrent endometriosis after doing TLH with BSO for endometriosis?
That's a very important thing. Unlucky gynecologist and unlucky patient for that. And you have removed everything, but still we find, I have seen a few cases where even after the surgery, but remember, in those surgeries, first of all, whether it's a recurrent disease due to your defective surgery or not. I think during the primary surgery is very, very important for that. In majority of the cases, you compromise with the surgery. If the ovary is there, you don't remove the ovary and don't dissect the ovary and then remove it, it will again recur it for that. But even with the, you have removed it, the microscopic lesion cannot be removed with the microscopic surgery. So that's why some cases will find for that. And recurrent endometriosis, there I've shown you that this is a case where the vault endometriosis is there, but the ovary is there. But the ovary is not there, ovary have removed it and then find this. I think you can go for the medical management for that, and GnRH analog or Dynogest could be an answer for that. The only thing bothers me, if there is a rectosigmoid endometriosis and there is a total constricting ring on that, and there you can go for a colostomy and other surgeries for that. Otherwise, you do.
Right, sir. Sir, another related question to endometriotic MRI part is that how do you assess the depth of scar of endometriosis? Do you do it with the pathological method or MRI is possible?
Adenomyosis?
No, endometriosis.
Endometriosis,
Depth of scar.
the extent of the lesion. I think this is a very important thing. MRI can give evidence. MRI is only useful not for ovarian endometrioma. It is only for rectosigmoid endometriosis or deep infiltrative endometriosis. The depth is important, and there the MRI can help you for that. Otherwise, in ovarian, it cannot help for that.
Right, sir. Now, there is another question from Dr. Bhagyalakshmi Nayak from Kazi Bazar. What's your experience on cancer progression from residual endometriosis?
Couple of cases I can cite. I have seen in my life 3 cases of endometriotic carcinoma, ovarian carcinoma, and a known case of endometriosis, pelvic endometriosis, chocolate cyst. I have seen earlier, and one case I still remember in the latest during the corona period, just beginning in the March, I found one case which presented with endometriosis about 3 months before, and I had given. I've done all investigations for that, and I had given leuprolide depot and 2 doses, and then planned for surgery for that. And unfortunately, the corona came, and she presented with severe pain abdomen in the month of March, last week of March. And when I saw that, and just before the shutdown, and did a sonography, and the sonography and the extent of the lesion has grown so much within 4 to 5 months that I gave a suspicion of malignancy for that. Along with that, the variegated consistency, the color Doppler changes and all that gave me a suspicion of that. And the extent of the lesion is so more retroperitoneal and all that. I kept a surgeon ready, and with the surgeon we cannot enter into the abdominal cavity. Hardly then I decided that it could be a carcinoma. I did a debulking, tumor clearance, total tumor clearance as far as possible. We did a debulking, and then the biopsy came as endometrial carcinoma. And unfortunately, the patient died after 1 month for that. That's a only case which I found. Another 2 cases, I find that endometrial carcinoma in my life for that. Whether it's originating de novo for that, or it is there with that. But the last case, the endometriosis was there since 1.5 years. 1.5 years. So I don't consider that this could be a de novo endometrial carcinoma for that.
Sir, again, Dr. Bhagyalakshmi Nayak is asking, like from Kazi Bazar. She asked about the depth of the scar, and now she's asking that is there the role of serum markers?
Serum markers in endometriosis, I think lot have been tried, because CA125, people are worried when there is an ovarian cyst, CA125 is raised. Endometrial cyst on sonography, color Doppler avascular, but CA125 is 80 or 100 like that. So these are the cases where endometriosis also CA125 is likely to rise. So therefore, the tumor markers are of no help in endometriosis. Maybe that in metabolomic and genomic and metabolomic markers in the near future can help it in diagnosing that.
Okay, so there's one more last query, sir, from again Dr. Manoranjan Mahapatra from Qatar. AMH estimation before and after conservative surgery.
I have already clarified that for medical legal purpose nowadays we advise that yes, AMH before and after should be done. And because quite a few cases of medical legal thing came, that we know that after cystectomy AMH is low. And if you have done, and there are studies that AMH is itself low in endometriosis. So if a document of AMH, lower AMH before surgery and after surgery is there, then you can say that yes, legally you are safe for that. But it is not very practicable in all cases, but at least so to have a medical legal point of view, you can do the AMH before and after that.
Right. So with this, sir, we are done with the questions, and thank you,
Dr. Diwan. I was so happy that my favorite students were interested, and Bhagyalakshmi, Manoranjan, Arati, and all these Alekta, all are my favorite students. They are genius. They can excel me. They do better surgery than me. They are better knowledgeable than me, and I am proud of them for that. And I'm proud that they have watched this teaching. I remember teaching them during their postgraduate period in dead of night, also up to 2 a.m., 3 a.m. during my emergencies. I'm really feeling that the same moment comes today after 10 to 15 years. And now I feel that they have grown up in such a manner that they have excelled me, and that is the greatest satisfaction on me.
Great, sir. Thank you so much, sir, for your presence and your deliberation.
Thank you.
Right, sir.
Thank you.
Thank you, sir.